Metronidazole is a drug which has been used for decades and still continues to be one of the most important bugs against many anaerobic and parasitic infections. It creates free radicals and is injurious to the DNA, and that's how its mechanism of action is. And it's active against anaerobes, facultative anaerobes, protozoa, available both as oral, IV, and also topical formulation, where it is mainly reserved for rosacea and bacterial vaginosis. And currently, it's used for intestinal and liver amoebiasis, sepsis for anaerobic coverage, bone and joint infection, endocarditis, skin and soft tissue infections, abdominal infections, pneumonia, meningitis, brain abscess, colorectal surgeries for prophylaxis, giardia, and Balantidium coli, H. pylori, where it's a part of the multi-drug therapy, Prevotella, and Porphyromonas. It's also one of the drugs which is used in C. diff infection. Vancomycin and fidaxomicin is preferred in non-serious infections. And when the patient is seriously sick, vancomycin is the drug of choice, but metronidazole may be added to vancomycin for additional coverage. So in serious C. diff, especially with ILS, IV metronidazole with oral or rectal vancomycin can be used. The usual dosing is 500 mg twice or thrice daily. The oral agent has 400 mg with excellent bioavailability. The major adverse effects due to metronidazole are carcinogenicity, metallic taste and GI upset, and neurological deficits, both central nervous system and peripheral nervous system. And we need to understand that there are conditions where we may use metronidazole for weeks, and that is where the neurological side effects come into the picture. Resistance has been shown to the metronidazole, and mainly because of its widespread use. And major concern is resistance among the bacteroids. For anaerobic infections, anaerobic cultures are done very infrequently, and thus the treatment is usually empirical. So in my ICU, we don't send anaerobic cultures for every patient like we send aerobic cultures, and so metronidazole always remains a part of the empirical therapy. And even after the culture report turnaround, if you still suspect that there could be an anaerobe involved, you continue with the drug. And the community resistance data is valuable in guiding therapy because of a large spread use of metronidazole on the community basis, because it is available on oral agent and one which is frequently used for diarrheal illness empirically. That is one of the concerns. The drug which has comparable anaerobic coverage, or ones which is kind of taken as a comparator, is a carbapenem. And so carbapenem anaerobic coverage is excellent, and the major concern now is situations where an anaerobe is resistant to both metronidazole and a carbapenem. Luckily, it's not very frequent, but because of widespread use, especially in South Asian countries, resistance to metronidazole among anaerobes may still be encountered. Our use in the intensive care unit of metronidazole is mainly as part of an empirical therapy, where we consider that there should be an anaerobic cover, and it's one of the drugs which is still probably the most reliable against anaerobic infections.